Yeah, I guess so.
Yeah. Good morning, good evening, depending on your location. My name is Wilson Sabiumba, the TORG member and the Director of Education and Training. I'm speaking from Rwanda. So it's my pleasure today to have you and having Mr. Augustin as the presenter of today for the very good presentation where he's going to share with us the overview of early infant male circumcision. I welcome you all. And before we start, I wish to thank everyone who joined, most especially the organizers of this webinar, Rwanda chapter, and also without forgetting to thank our CEO and founder of TORG, Madam Adebsola. Most welcome. So without taking much time, let me welcome Dani to introduce our speaker. Thank you very much. You are welcome, Dani.
Thank you very much, Wilson. And you are most welcome. It has been a while without having such session, so I'm happy today to be around and meeting you again. So, ladies and gentlemen, let us welcome Mr. Augustin. Please join us in welcoming Augustin Ntakirutimana, the technical officer at Jhpiego, male circumcision master trainer, a special project coordinator, and is as well a part of TORG chapter of Rwanda. So it is my pleasure to introduce our esteemed speaker for today's webinar, Mr. Augustin Ntakirutimana, a skilled nurse holding Bachelor of Science in Nursing from University of Kenya. He is currently works at Jhpiego as an environmental sanitation and infection prevention control technical officer, supporting improvement of patient safety and infection control standard across the Rwandan health facilities. With over 5 years of hands-on experience in volunteering medical male circumcision project, Mr. Augustin is nationally recognized male circumcision master trainer. He has trained the mentored health providers across various levels of health system, ensuring the delivery of safety and high-quality circumcision services across the country. In addition, Ms. Augustin serves as special project coordinator for the Operating Room Global Chapter Rwanda, where he contributes to initiative to strengthen surgical care, infection prevention, and health system performance in rural resources settings, like ours here in Rwanda. So, Mr. Augustin's presentation today will focus on early infant male circumcision, screening, procedures, benefits, complications, and as well as management. His presentation will offer a technical guidance on the current eligibility, safety procedure steps, advantage of early circumcision, and effective management of potential complications, providing valuable insight for practitioner, policymakers, and program implementers alike. So we are all excited to have Augustin with us and look forward to engaging and insightful session. So, Mr. Augustin, you are most welcome for the session.
Thank you all for your warm welcome to me, and thank you, Wilson, for introducing our session. Today, we are going to talk about the early infant male circumcision, where we will focus on the key component of EIMC as an introduction and the review overview. Then we will be having time to move forward to know more about early infant male circumcision. We are trying to share our screen, but I'm with Mr. Wilson, where we're going to share the same computer. I hope everyone can see my screen. Everyone can see the screen?
Yeah.
Okay, thank you.
Yes, it is spread.
We can see it.
Can see it. Thank you. So, as an overview for early infant male circumcision, we are going to look about EIMC screening, procedure, benefit, and the complication management. As we may know, the early infant male circumcision is the oldest surgical procedure that was performed across the world, where more male were circumcised from different age, from different culture. For Rwanda and the UNAIDS and WHO have recommended male circumcision for its benefit to prevent HIV, where the circumcision can reduce up to 60% risk of acquiring HIV from infected female partner. We'll be focusing on EIMC as a long-term solution where you can implement to sustain the procedure and the safety of its procedure. As we define this, the EIMC is performed between the age of 1 to 60. It's where we prefer with the lower risk and the low complication. EIMC is preferred over adult because the procedure is simple. It can be performed by well-trained provider for short time. The cost for this procedure is cheap and the complication is fewer, as I said before. Even you can know that EIMC can be easily integrated in the MNH package through newborn care services, where we can review the different programs for MNH, such as immunization and the antenatal care for our mothers. For example, for Rwandan cases, we found that more than 99% of women perform antenatal care and deliver at health facilities, and we found around 98% of born infants, including 50% of male, receive the first dose of immunization, which is administered for the first 60 days at 45 days of birth. HIV comprehensive services include VMMC, which is voluntary medical circumcision, where we have 2 packages for adults and the infants package. And this infant package was prioritized with the National Strategic Plan to control HIV as a long-term solution, where the Rwanda country, the case of Rwanda, 11 hospitals have been trained to perform this in a scale-up phase. To go deep in this exercise, we will focus on the penile anatomy before we go to circumcision. The infant's penile anatomy differ a bit with the adult's penile anatomy, where we found different focus to the foreskin and the glandular structure. As you can see to this picture, we may found the prepuce, which cover the penile, the infant penile glands, which present the corona prominent and sulcus below in. Here you can highlight this with a pointer. This is the corona prominent. This is the outer side. You can find also the shaft of the penis here. For the prepuce is made of two skin tissues where there is the outer foreskin and the inner foreskin, which is made branded in red down and cover the glands. For the infants, the prepuceus sphincter here is very tight in most of infants, where we cannot easily visualize the meatus. On the other side, the inner mucosa from the prepuce are most of the time attached, or it is there's adhesions with the inner foreskin of the glands, where we will look how to go to separate or to separate this inner foreskin from the glands, and the way you can dilate the prepuceus sphincter to visualize the urethra meatus. This is essential exercise we have to perform before performing the EIMC procedure. On the other side, on the lower side of the frenulum, it is highly vascularized for side of the penis, and it is more closer to the urethra. This side, it is measure less than 0.2 millimeters, which is mostly made with the skin. As you see on the pic, you can find it's a big distance, but it's very low. For infants, penile diameter from the side up to down, it can measure around 1.1 cm. It's around 11 millimeters. Other structure from the penile anatomy, there is a surrounding structure which is made of testes and the pubis up. So most of the benefits, as we said before on the introduction, they have said that there is a reduction of the risk of acquiring HIV and other sexual transmitted infection in adulthood. If the infant is circumcised, there is a protection from the future. The main benefits for EIMC, it's where the risk of UTI is 10 times less in circumcised male. This is a potential benefit that an infant, if circumcised, can receive, and most of the infants, around 50% of infants that we receive in the health facilities has UTI-associated conditions. Other benefits, we found that there is prevention of phimosis, prevention of paraphimosis, balanitis, osteitis, decreased risk of cancer, the penis, and the risk of cervical cancer in female partner for the future. And also, the female partner have reduced risk of trichomonas vaginalis transmission infection while it is adult. The timing for circumcision during infants, there is no ideal time identified for make circumcision. For any age, you can perform circumcision, but it is best preferred when it is performed during infants, where you have found experts that suggest that the procedure can be easy and associated with less pain. The pain for infants and the adults are different based on the study what was done. If the surgery is done for the first 2 months, the pain is less and the complications are fewer due to the infants have short arms that the infant cannot have long arms that can be longer than, they cannot touch the lower and the lower umbilicus areas, and the infants cannot have complications related to erection when it is circumcised. As from the American Academy Family Practice recommend performing circumcision no less than 24 hours because the baby has to be examined to rule out other complications related to infants. During this time, it's where you can confirm the preterm delivery of preterm infants. The baby with low birth weight, they measure the baby weight. If it is less than 250 grams, the baby will not be circumcised. Other complications that you can differ to EIMC, there is hematological disorders, jaundice, and other congenital abnormalities which can be found. During the first hour, it's where some changes can appear to the newborn infant. About screening, better to look about the eligibility for surgery as you do for other OT procedures. To rule about the eligibility for surgery, today we focus on history taking, clinical assessment. For the family on the baby, we assess different inclusion and exclusion criteria. For exclusion criteria, we found the breathing disorders for the baby or the family. Even we can assess the umbilical cord for the baby while it is on birth. If there is a presented breathing, this baby will be excluded. If there is any risk of breathing from the family, we exclude the baby. Then after, we ensure that we assess the pregnancy and delivery history, how it is performed, that it was held up. And we ensure that all baby with normal physical examination and the intact penis with normal appearance should be considered for circumcision. On this point, last bullet, we mostly consider key structures for the penis, such as hypospadias, the length of the penis. If the infant penis is less than 1 cm, that baby will not be circumcised at the time. Here regards on the pain management units. As in adult, in the other procedure, WHO recommends the use of local anesthetic for infant circumcision. Most of the time, we prefer and we recommend to use lignocaine without epinephrine. 1% lignocaine is used, and we set the 1 ml based on kg of the baby. The total recommended maximum safe dose for lignocaine is 3 mg per kg per body weight, where we can take 1 ml, which is equal to 9 mg per 3 kg. Most of the baby, and the average weight of the baby is around 2.5 to 4 kilograms. During administering anesthetics, we recommend to use a dorsopenile nerve block, where 0.5 is given on one side at 10 o'clock side, and this other remaining quantity will be administered at 2. We can say why we give to 10 and 2. For the anatomy, we saw that the dorsal side of the infant penis is made of blood vessels. There is dorsal vein and 2 arteries. We go to 10 and 2 to not have a risk to inject our lignocaine within the vein, which will be high risk from anesthesia. Provider must be evaluated, as we said before, to eliminate the risk for anesthesia, which will be dangerous. About the BTNB, the injection of local anesthesia should only be considered in setting where there is a reliable access to sterile needle and the way incision protocol have been established to ensure safe handling and disposal of contaminated shafts. We also ensure reanimation equipment so that the baby can cry, vomit, or can have other risk of anesthesia. To administer anesthesia, it's better to choose the syringe with a small gauge, 27 or 30 gauge needle, to be inserted for the mentioned area of 2 and 10. The position and the injection to the depth of 3 or 0.5 to not traumatize the other structure made of the penis, which is inserted into the subcutaneous tissues below the penis, and it is given at 45 degrees from the base of the penis. Most complications related to DPNB are bleeding, bruising, inadequate analgesia, small hematoma, and DPNB is the best described how to administer. This will say that the risk of bleeding, bruising, inadequate analgesia, and small hematoma, because during injection, the baby can are traumatized with the needle. So why we prefer to use the small gauge, which is 25 and 30 gauge. And why this is the best described, why do we give this? It is the one who do not maintain the penile anatomy. Other methods we can use is the subcutaneous ring block. The subcutaneous ring block, it gives the penile edematous. The infant penis is small. Why you do the ring block? It make edema. That's why you prefer to do the DPNB, which maintain the penis anatomy. Other option we can use, there is EMRA cream, which is made of lidocaine and lidocaine. Is used for some devices such as Prasibel and the Gomoko clamp. Even the Morgan clamp can use this, but it takes long. When you apply this type of anesthesia, analgesia, that EMRA can take around 60 to 80 minutes waiting for the procedure to have effect. And most of infants are not comfortable with the position that we have to put the cream and you maintain to maintain the cream on its penis. Baby can remove it or can cry, cannot be comfortable with it, and you do not prefer this. But for the EIMC using Morgan clamp device, we prefer to use injectable analgesia. Other option you can use the breast milk. The mother can breast the infant during the circumcision. After giving analgesia, you give analgesia to maintain the comfort. You give breast milk and you can breastfeed the baby. Other option, you can use a sucrose, the sugar, the normal sugar you have. You wrap it in a Vaseline in a gauze. Wrap it in a gauze. You put on small normal saline, sterile one, and you make the baby to suck it. This is another option that's to maintain our analgesia and the comfort of the baby. As a take-home and recommendation for EIMC, the sedation should not be used for performing male circumcision. It should be avoided because of the serious complications that can develop with sedation. Most of our anesthetic staff knows how to sedate and to maintain baby during sedation is hard. Cannot perform this to sedate the baby while going to circumcise. Use this option to give local anesthesia, which is equally 1%. Then we use such option breastfeeding or sucrose to sustain or to maintain the anesthesia. Here are some devices that are used for EIMC. We'll add more about some picture here. This is the price belt. It's there's the belt which is a leg of the church. If that's the name comes from. We place this on within the foreskin. You use this rope to tie the foreskin, then you break the handle. Then after the foreskin will be necrotized. This is the one of the clamping device we use. This also works with the other called the shangling device. Is a new one from China. The shangling device have the smaller size Y, size Z, which is used for EMC. We also have the Gomco clamp. It's the American made with different size. This is the one used to cover the gland. You apply within this device, then the penis, the foreskin is attached outer to the device, this one, which is which I'm pointing with the red pointer. Then you exercise. This is meant to minimize the risk of glandular injury. The other device I can talk, it's about the aqua silk. I will talk about the mahogany clamp after because it's the one we're going to discuss about. The aqua silk device is the device which is made for circumcision. This is inserted within this device. Then you lock, you adjust the foreskin on out of this. Then you lock the device. The device aqua silk also have the glove or stitches that is automatically applied to the circumcised to the incised area. On the last, I want to talk about the mahogany clamp. Mahogany clamp is the device that is introduced to Rwanda, which is made of two. I can show this. I have one here. This is made of two faces. There is the concave face. There is a flat side. The concave face that face the glands. There is a lever that is used to lock the device. The lever is used to lock the device while circumcision is done. We will also ensure that the device aperture, the opening of the device inside here, we have to be less than 2.5 millimeters. Can be to less than 2.5. That's the device, the self aperture of the device. Technical procedure preparation. Can you see here are the devices here and some key supplies that we can prepare, we can see on the table, but we can talk about it. We need to ensure that the baby is ready and the screening is performed. We need to ensure the availability of equipment supplies on the site. They provide the information to the parent, the guardians, obtain from the consent. They look at the current consent form to see if the consent or asset is signed. The provider have to slowly wash and clean hands, and also the provider need to perform patient screening again. When we talk about the equipment supplies, we need to have the device ready and sterile. Need to have the Vaseline gauze. Need to have the gauze swab, surgical braid, size 10, forceps, 3 to 4 forceps. Need to have painkiller, anesthesia, and paracetamol. Suppository, 250 to maintain the pain after the procedure. And we need to ensure that we have a pamper, the pads, that to wear the baby after the procedure. Here are some steps that we go through. We have around 14 steps that we have go through to quick circumcision. The first step is to ensure the baby is restrained, is supported for the procedure, cannot harm. We can use two ways to restrain the infants. One is to restrain the infants using your arms. The assistant will restrain the baby and allow the operating area, the circumcision site available, and ready to the operator, to the providers. The other option is to use a circumstrain. There is a bay where the baby is restrained. The legs, arms are restrained within a circumstrain. You can go to, you'll go search and you see how the circumstrain is made. I do not have one here to show you, but the circumstrain are used for infants for circumcision. Step 2, there is skin preparation. We use a standard and approved solution. Here in Rwanda, we use iodine to circumcise infants. In most of the country, some due to allergy to iodine used to wash out with normal saline after 3 painting and wait 3 to 5 minutes after cleaning the surgical site. On step 3, we ensure infiltration of local anesthesia. We know we have said before that the DPNB is the way and the preferred method to provide local anesthesia. The local anesthesia, I say, is administered at the base of the penis using a small gauge needle, and we administer 0.5 at one side at 10, and the other remaining 0.5 are given at 2. The dorsal part is the side of the vein and arteries and nerve. We don't allow anyone to give anesthesia at the dorsal side. We give at 10 and 2. After administering anesthesia, we perform draping. We use a fenestrated drape to drape the surgical site. After draping, we ensure and identify the corona gland penis, the corona prominent to the penis. We palpate and we found the corona prominent site where we make a circumcision line, which is different to adults. For adults, the circumcision line is made 0.5 below the corona prominent. But in infant circumcision, the circumcision mark is made at the corona prominent, direct to corona prominent. Adhesiosis for inner mucosa. Before in anatomy, I will say that the infants have adhesions and tight frenula and tight prepucial sphincter. We need to free and identify the urethra opening. We release adhesion by entering a curved or a flexible probe into the foreskin. Use gently movement from 5 to 7 o'clock. We don't move up to 6. We make a half circle from 5 to 7 because at 6 it is the frenula area and we don't allow anyone. The procedure do not allow you to touch the frenulum because you can tear the frenulum and cause bleeding. We need to pay attention to the glands, the risk of injury to meatus and frenulum, as I said. And see on the pic how we make adhesiosis. Step 7B, after separate or dilatate the prepucial sphincter, we pull up the foreskin and you visualize the glands and you remove the remaining adhesions using the tip of the forceps or your flexible probe when you are having on your side. Step 8, we pull up the foreskin after adhesiosis and we palpate the glands to ensure that the marked line is still accurate after adhesiosis. At this site, you apply, you go into the procedure and apply the 3 forceps that you're having on your side. One is applied at 3 o'clock when you are set to the penis, other to 9 o'clock, and the straight one is applied at 12 o'clock. While applying the 12 o'clock, we insert these forceps, tenting the foreskin to minimize, to limit, and to avoid the risk of glandular injury. If you tent the foreskin, you reach to the gland, to the sulcus area, and you pull up 0.2 to 5 cm, the distance, to do not traumatize the remaining structure, or you reach up 0.2 up to the marked line. On step 9, we maintain the dorsal forceps, which is applied to up to 12, and you remove the 2 remaining. You palpate the gland, you pinch, and you push down the glands, and that is made using your finger and the thumb tightly. Then you pinch directly. The dorsal forceps applied at 12 will be your guide while inserting the device. And the device is inserted at 12 to 6, from 12 to the frenulum, making 45 degrees. This 45 is to ensure that the frenulum is not traumatized. We will also ensure that the device inserted goes along the marked circumcision line. After inserting the device and ensure that the device is moving along the circumcision line, we close the lever using your small finger and you lock your device. As you see on the next picture, the provider holds the dorsal forceps and the device using the thumb and the index finger. They hold the device, and the remaining, the small finger and the annular hold the forceps. The device and the foreskin is free for excision using the surgical blade as we mentioned the surprise provided. This is the way you excise the foreskin. The foreskin is incised with a scalpel using the outer flat side of the device, the Mogri clamp, as a guide. After the 5-minute clash time, you apply the device, you maintain it up to 5 minutes. After 5 minutes, you relieve the lever. The lever I said is this one here. You can see this lever is open on this side, this way. Then you release it. After releasing the lever, you use your thumb, the two thumbs of your arms. There is one inside to your arm, and use your thumb to deliver the glands. While delivering the glands, you ensure that the foreskin, the outer, is fully removed and the shaft do not go far from the corona prominent, just below to corona prominent, and you fix. This procedure do not need any suture because the device only use the clamping system to do hemostasis. There is less bleeding during this procedure. As you see for the two picture, the circumcision is done for up to this step. Here we can talk about the safety of Mogri clamp. I have said before, we need to ensure the device aperture need to be no greater than 2.5 centimeters. Because if the device is too big, can you open widely, they can accidentally trap the glandular tip side, and it can be clashed within. The device can clamp the tip of the penis. That's why you need to have a small aperture to the device. If you have devices with the aperture which is more than 2.5, you need to remove from your device to use. That's why you need to use the device with correct opening aperture. We need also to ensure all adhesions are fully removed. If adhesions are not removed, you may find that while releasing this step, the last step, while releasing the glands, the foreskin, outer foreskin will come and the inner foreskin remain attached to the glans penis. Next, we need to palpate before gland application. Why we need to palpate? We palpate the penis to ensure that the gland is free and can move down. All adhesions are removed. Other common complications that you can find on the device safety, we need to ensure that the circumcision mark line is made on the real side to the corona prominent to mitigate the removal of insufficient skin removal. We need also to ensure that skin bridge are not formed to the penis. We will see that how the bridge can be formed, where the shaft can move up to the gland penis. Because they will have make adhesiosis, the circumcision line, the marked line, where there is the cut take place, can move up and adhere to the upside. Other complication that we note is a minor bleeding are noted during circumcision for that time. Postoperative care and precaution. During postoperative, is example to ensuring outcome. Postoperative dressing is performed within 24 to 48 hours, but they can be also safely removed and continue to use the diapers. The foreskin is reduced. You need to ensure that the foreskin is routinely reduced to not form adhesions. Apply regular amount of Vaseline while performing dressing to minimize the risk of urethral meatus stenosis. And you wrap up around the shaft, the penis, the gauze, ensure the gland can be visualized while performing the dressing. And ensure that the dressing cannot take longer than this. Here are some long practice that we can show you for long and poorly applied dressing. This dressing can block the blood flow and it can block the urine flow. That we need to ensure that the dressing is performed as the way. Here are the way to apply dressing. Step 1, you take the Vaseline gauze and apply around the circumcision wound. After applying the dressing using a Vaseline gauze, you fold the gauze, the gauze towel around the penis, not apply out. You apply up, then you put the diapers and you close the penis like this. As step 1, you fold. Step 2, you around the penis. Step 3, you wrap up the gauze, then you put diapers. During the post removal of the wound, post care of the wound, after 24 hours, you remove that dressing and you leave baby wearing his pads and apply the petrolatum, the Vaseline gauze, white one, to around the wound and put on the diapers. Nothing more than this. And continue with pain management medication. EIMC problem, I have said that you need to ensure that the baby is not have to be returned to the clinic for any reason. If he's sick, you can come to the clinic. If he's lethargic, if fever, does not wake up, and all of this will not be associated with circumcision. You need to make, as usual, the follow-up of the baby, and you need to ensure that the wound is still intact or no wound well-being. Risk and management for this procedure, when they perform the way with the trained and the experienced provider, care, complication are manner and layer for the procedure. For the research done, you can find 1 out of 50 cases. But if this is performed with a non-formal training and formal policy, equipment resource complication are high, up to 20% if you are not trained. That you need to ensure that everyone who performs this procedure has to be trained to minimize the risk of complications. Some risk you can find with this program can find that is a concern that the kid cannot provide the consent, there's pain, there's bleeding, there are threatening condition, infection, injury to the penis. I said before, if the aperture is big, poor cosmetic, if the circumcision mark is not done, meningitis can be happen if there is not enough petroleum applied to the dressing, and also reaction to anesthetic agent can happen while doing circumcision. Other complication related to the Morgan clamp device, we know that the Morgan clamp is a simple and fast, but is associated with the extremely rare distal tip penile amputation if the aperture is big. This injury can occur regardless to the level of experience of provider, despite the precaution continue to occur in the US as research done to this column. Some complication I write in this table, there is a removal of excessive or an insufficient amount. Can you find this difficult? Urethra injury, I saw that the urethra and the skin are closer to the penile area. Penile isolation amputation can occur. Urinary retention to the bladder if there is a retained pad or a BC2 other device, but for the dressing, I have to say they have to be not tight. And the other is infection if there is poor hygiene during the procedure. So I can thank you everyone here for the presentation, and we'll come to question and the other supplement to this presentation. Thank you all for your attention and good attendance.
All right, thank you very much, Augustin. It was a pleasure to have such an insightful session. So we are now entering the session of questions, and let me call to discussions. So, because as we are here, we are from different countries, from different cultures. So this is a good time to see how this procedure is being done from the other side of the world. I've seen here in the chat group we have a number of questions. Starting from Jackson, he was just wondering what is the global impact this program. Excuse me a bit. What is the global impact this program has, so everyone can take the message to their countries? So is every country allowing male circumcision to be done by nurses? So people from different countries here, we are going to share how it is being done or done by who. Then point to learn and show people in the it can be done globally. This reduces cost in many ways. So, Augustine, do you have any idea about this?
Yeah, I have an idea on this. When you come to the global impact for EIMC, as you have said that the EIMC is a long-term solution for HIV prevention, we focus with the PEPFAR have recommended, PEPFAR, UNES, and WHO have recommended male circumcision in countries where the male circumcision is low and the HIV prevalence is high. They have preferred around 14 countries in Africa to implement the program. The program will first target the adults for 18 and above through campaign. Thereafter, the target group have decreased from 15 and above, and some organizations prefer to circumcise from 10 and above. But the prevalence of circumcision and HIV are still high as usual, and the impact to this program is when the circumcision is integrated in early infants and integrated in preschool education. If this is performed and every infant's male born is circumcised, the prevention, the target to HIV prevalence will be clearly reduced. But some implementers do not implement this program due to cost and fear of complications, because the training cost is high.
All right, Augustin. So he was even wondering if in different countries nurses are allowed to do such kind of procedures.
Okay, thank you. In 2007, WHO and UNES widely recommending the EIMC and the adult male circumcision. They have allowed nurses and other professional healthcare providers to be trained to perform male circumcision. The protocol is there, but the countries is their way to adopt into its national strategic plan to perform male circumcision. Nurses, clinical officers, midwives, and the other cadre of healthcare providers are allowed to perform male circumcision.
All right, thank you very much. And also, Moka Committee is asking if early male circumcision cannot prevent the penile to grow. Is it true?
Okay, thank you for the question and the concern. Some parents or guardians used to ask such questions. I can say no, because when you are, even in adults, the size of the penis are not equal. There is some we can found there is a big size, small size, but there is a range for the penis. When circumcising, you remove the outer foreskin, only the foreskin. In the foreskin, there is no research that have approved the foreskin play any role in the penile growth. Only the growth of the penis is made of its anatomy. The anatomy of the penis is made of two muscles. There is a cavernous spongiosa, which there are two muscles of cavernous spongiosa and another method that lie in the urethra meatus. So those two muscles are the principal key for the penile growth. That's why you cannot found why the foreskin only are the key to the penile growth. That's long. I hope that if I tackle to the question.
All right, thank you very much. And also, someone was wondering, like, if penile amputation happened during the procedure, is there any recommended management?
Okay, thank you for the question. That was one of the serious complications that can occur during the male circumcision. During EIMC, there is a possible, there's possibility to have a penile amputation, mostly the tip of the penis. But if the tip of the penis or the penile is amputated, the gland is or injured, we need to ensure the management of the penis. We work with the plastic surgeons, but there is the emergency care to the infants and the amputated part. What we can do? We have to ensure the referral guideline is in place and the transfer is immediately done to specialized health facility for care and management. The first we do is to reassure the parent and the healthcare provider have to be assured. Then we take the amputated parts and you take in a sterile gauze with and kept in a sterile materials. For example, you can use the gloves, sterile gloves. We keep this in ice. We take ice to transport the amputated part up to the impending referral health facility. While referring this patient, we need to ensure the small catheter is inserted to maintain patient voiding, and you make a light compression to the penis to minimize bleeding. That's the way we do to refer. The transfer of the amputated part will not be more than 3 hours and be repressed to the amputated part.
All right, thank you very much, Augustin. So now it's open discussion. Everybody would share the insight or how they do back at their countries. So everyone is welcome now to give the insight. So if nobody in the background, also in the chat, Pierre to say was saying back at their home, they have seen unprofessional or untrained people doing such kind of procedures, which result in very serious consequences. So he was just wondering if how do we do it here in Rwanda to reduce the risk of such kind of incidents? Do we have policy and protocols to follow?
Yes,
I think Pierre want to ask such kind of things.
Sure. Thank you for the concern. For Rwanda, the program was introduced in 2014, but from severe adverse event that was noted, there's 2 cases of distal tip amputation. The program was halted, and only trained and licensed healthcare providers are allowed to perform the procedure. And those trained hospitals are marked. We have 11 across the country that is allowed to perform EIMC. There is a 60 within the central area and the 3 on the border side. So if I can mention those hospitals, we have in Nyagatare, Butaro, Ruhengeri, and Gisenyi for the border side. Then in Kigali, we have Kibagabaga and Muhima Hospital. In the east, we have Kibungo and the Rwamagana are such hospital that are allowed to perform EIMC across the country. We're including the private hospitals like Kinifais Hospital is the one, and the Pioneer Hospital to perform EIMC. That's only all hospital allowed to perform EIMC. Thank you.
Thank you very much, Mr. Augustin. So now we would love to welcome our President, Adepsora. So, dear President, the floor is yours.
Thank you so much, everyone. I would like to say thank you to the speaker. That was very detailed and it was really, really practical as I left a comment previously and said, you are a pro at what you do. You are really good at what you do. Thank you so much for taking the time to put all of that together. It was really, really good to see. From some of us, we have the experience from parenting. You understand when you had to take your son for circumcision. And I think the second time I wasn't really happy with the professional, and well, everything went well eventually, but it's really good to see the steps and someone really explain to you what is involved in that. So thank you so much for explaining. I would like to say thank you to the TORG-RW chapter. Thank you for facilitating and for organizing the session. And I would like to say thank you as well to everyone who connected from all over the world. Thank you for joining. Thank you for actively participating. I think the next one, there would be another session next weekend organized by the Zimbabwe chapter. And there is another one in the next 2 weeks as well, in collaboration with our partner TROGS. I would like everyone to register for the upcoming sessions and join as well. So thank you to everyone. Thank you to our speaker, Mr. Augustin. Thank you for connecting. It was a real pleasure meeting you for the first time in Rwanda. I think that was about 2 months ago. And thank you to everyone, to the chapter. Thank you to everyone, every member, every leader. Thank you for connecting. And we will definitely see you again. So all the best. Good morning, good afternoon, good evening, depending on your time zones. Have a nice day. Thank you so, so much. Thanks, Mr. Wilson. I can see you. Thank you. Thank you so much. Thank you, Danny, for organizing. Thank you so much. Bye. Bye.
Bye.